So welcome to our clinic today, where we're going to be treating a few full face cases with filler. The purpose of today is to demonstrate a few patient journeys from the consultation through to the treatment. And we're also going to bring the patients back and show some of the results as well. The focus is really on the techniques that we learn and the filler placement targets, which illustrate the global evidence matrix, which is the new methodology we're using at Harley Academy to instruct exactly where we want the filler to go based on the gels that we choose for our patients. So these cases have been selected for a variety of reasons. Usually they are suitable for full face treatments. They have natural aesthetics and they have sometimes challenging targets that we want to be able to address and educate on. So throughout the variety of these cases, I hope you learned something, and without further ado, let's get started with the first case. Amy, welcome to clinic.
Thank you.
You've been here before at our academy. Could you tell us a little bit about things you've had in the past? That'd be really helpful to understand.
Yeah, I've had a bit of lip filler previously a few years ago, like 3 years ago, and I've had Botox probably about 5 months ago maybe.
Okay.
And I previously had a bit of filler in my cheeks, and I think in my temple.
In your temple as well?
I think so, but I can't actually remember.
Speak a little bit. From memory, what was the happiest you've ever been from a treatment? What was the zone? When was it done?
Oh, it was a few years ago. I had some profile balancing done, and I just thought it made me look so much kind of refreshed, and like it really just evened out my face.
Very good. So profile balancing, normally what we're talking about there is things like foreheads, noses, chins, lips, everything on profile. So we'll definitely look at that. We've done the whole history off camera. And so if I was to ask you what the number one thing that bothers you when you look in the mirror right now, what would you say that is?
Probably a little bit of hollowing under my eyes.
Under the eyes?
Yeah, that's probably what bothers me the most, yeah.
Got it. And do you mind telling us how old you are?
I am 30.
You're 30. Okay, so now let's look straight into the camera. You're 30 years old, and where's your genetics from, your family?
So some of my family are Scottish, and I've got a great grandmother who was Indian.
Indian. Oh wow. Okay.
So a little bit of a mix, but my granddad also has some, I think it's Turkish family as well, which yeah, hence the dark hair.
Got it. So let's take a look systematically now at the face. So the first thing we'll do is the overall impression. I think we can say very attractive features, very nice skin texture, and relatively symmetrical throughout. The things that stand out to me are these beautiful curves from the brow down to the midline of the nose, these very aesthetic lines. The lips have been treated, and I think they're in a position where I'm very happy with those lips. I don't want to add any more volume to those lips, and I think it would be a mistake to add additional volume relative to the rest of the features of the face. I think that there are some opportunities as well. So let's look at the vertical thirds. So hairline to the glabella, glabella to the base of the nose, and base of the nose to the base of the chin. We have good equal vertical thirds. And let's staying with the upper third. I'm very happy with the brows. We turn all the way this way, and I think we've got a very nice youthful forehead convexity as well. The temples, although they have a shadow, I don't think they are particularly worth treating in a young patient where we have good tail of the brow support. If you see the height between the tail of the brow and the lateral canthus of the eye, often we would treat this in a younger patient when we really want to create some brow elevation like this. Aesthetically though, I'm not convinced this is actually going to be of benefit to Amy, so I'm going to leave the temples well alone. We look now at the periorbital complex, and I noticed that there is a shadow under the eye, a kind of tear trough presentation. If you look upwards and eyes upwards and chin down, we can definitely see the shadow under the eye, and I just want to help to differentiate between what is a tear trough, and if you close your eye for me, and I'm just going to press here, and what is actually intra-orbital fat herniating or pseudo-herniating. And you see some of these irregularities are because we have fat within the orbit pushing down against the orbital septum and creating these shadows. Just open your eyes. And so it's important in patients like this, if they say their concern is actually the under eye, we have to make them aware that we can't create a perfectly smooth transition from the cheek to the lid because we have anatomical factors, intrinsic factors that change the fundamental anatomy of the face. And so what we can do is we can help to smooth over those irregularities. I do think an under eye treatment would be beneficial for Amye. Staying with the mid-face, she has good, deep volume support. And so she hasn't experienced this significant age-related volume loss. It would be nice to just amplify the beauty in the mid-face by creating a apex, a light reflex at the cheek apex. And this would be a really nice aesthetic additional feature for the face. And when we do that, we can create a little bit more projection, subtle definition along the cheekbone, which I think will be quite striking in this face. But I'm not trying to create a huge amount of projection here because, as you can see, she already has good projection to the lateral zygoma and a nice area of kind of converse hollowing here, which often can be a target for volumizing fillers. But again, I'm not going to see a huge benefit from adding volume back here because I'm not intending to try and lift along the jawline. And so ordinarily the temples and this area could be good targets, but not for today. I think we've got a cheek apex and lateral zygoma definition and under eye indication, certainly. Moving towards the deep piriform space, I just noticed that we have a little bit of retrusion of the maxillary bone, and I've got a good centimetre of depth here, and I think by adding some support down onto bone here, we're going to reduce the depth of this shadow, which is by the base of the nose. And I think in doing so, that will also help to rebalance the profile of the face and support the mid-face. So I think the Pyriform Fossa is a good treatment in this case. Staying with the mid-face, finally, the nose, and I think she has a beautiful nose, particularly on profile. You can see this very aesthetic nose. There is a very subtle dorsal hump, and I think we can improve the straightness of the nose with a touch of filler above the dorsal hump, and in the process, create a strip of filler down the midline, which is going to create a much more narrow light reflex, which will give the illusion of a much more narrow nose. So I think the nose is a good target. I'm happy with the columella and I'm happy with the tip. And so this is a relatively straightforward cannula treatment to the dorsum of the nose. Finishing touches in the lower third. Well, if you bite your teeth together for me, we've got strong masseter muscles, but looking straight into the camera for me, you'll see that the bigonial width is narrower than the bizygomatic width. So despite the strength of these muscles, which is giving this really strong, beautiful jawline, I don't worry about the width here, but I certainly wouldn't want to add any more volume here. The chin itself is slightly squared off at the base, and I'd like to create a bit more of a feminine projection in the inferior direction and possibly soften this labiomental crease as well. And so in summary, this is a full face treatment, but predominantly focusing on the mid face, the under eyes, and the nose and the chin. I would call this more of a beautification treatment rather than a restoration type treatment, with the objective of creating enhancement to existing beauty. Does that sound good?
Oh, sounds great to me. Thank you.
Any questions on that?
None at all.
All right.
Sorry to interrupt this video. Hi, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I'm the one doing the injection that you're watching right now. I just want to take a moment to talk about our injectables diploma. So Harley Academy is a higher education college for aesthetic medicine based out of the centre of London, UK. And over 3,000 medical professionals have gone through our academic programs to achieve a postgraduate diploma in aesthetics. They will get a title after their name, PG Dip Aesthetics. If you want to learn more about our programs, how you can gain your qualification and learn how to inject in a really structured, systematic and evidence-based way, then click on the details below and our team will be happy to have a conversation with you. Right, that's enough from me. Let's get back to the video. But if you are enjoying this and you want to see more content like this, please subscribe and click like.
So let's start with the mid-face treatment plan that we've discussed. I mentioned that we wanted to create some definition at the cheek apex and a little bit along the zygomatic bone laterally. So let's start off by drawing the cheekbone itself, the zygomatic arch, following the natural direction of the bony zygomatic arch. That's important because we want to follow what's naturally there to create the most natural results. The second thing we're going to do is we're going to identify the apex of the cheek. I grab the lateral bone here, the lateral orbital bone. In the midline between those two aspects of the bone, we can draw a vertical line down. And we can sort of see here where the intersection is between the base of the nose and the tragus, another line. This would give us an indication of where we would want the point of maximal projection of that cheekbone. In females, it's slightly lateral and superior. In men, it might be more medial and inferior. And we're trying to create this lovely high feminine apex where the light bounces off. And I think we can see here exactly where we'd want that to occur. And then the objective is then to transition that into a really nice tail of the cheekbone so that this area that I'm shading becomes the projected area. We can achieve that with a cannula treatment, making an entry point here, creating this projection in layer 4 behind the muscle, and then tapering off laterally in layer 2. So let's do that on one side and take a look. So we make our entry point just through the skin. 1, 2, 3. And then let's go through the layers together. So we go into the subcutaneous depth. Okay, we don't want to treat in this depth in this part of the face. We're going to push through layer 3, which is in this part of the face is the orbicularis oculi muscle, and see that dimpling there? That's me moving just there. Here, I'm in the SOOF. This is the fat pad directly beneath orbicularis oculi, and I'm going to add some projection here. .25 mils. Once I've done that, I'm going to come back to the place I started and then track in the subcutaneous depth. And I'm going to pass this all the way down the zygomatic arch. And this is how we can create that shape underneath the skin of this really nice contour of the cheekbone. I'm deliberately trying to create a nice angle like this, which I think will look very aesthetic. And we connect this to the apex that we've just created. The reason why I'm happy to be subcutaneous in this part of the face is because it doesn't move when the patient smiles. But if you give me a big smile again, my finger moves like this, and then relax, and smile again, it doesn't move, because this is the fixed midface, and this is the mobile midface. And that is an important way to appreciate the depth of the injections that we're doing.
In caution from vessels like this, we've got deep vessels really in the subzygomatically, but we're thinking about the superficial temporal artery when we're advancing our cannula into that lateral bit, so that would be an area of caution, would you say, Tris, when you're
and you can feel that. So if you just feel just in front of the tragus 1 centimeter up, you can feel a pulsation always here where you'll find your superficial temporal artery. And so, as Joe mentioned, that's running much deeper within the hairline. And so when you're treating that lateral zygomatic arch, you don't want to extend all the way because, first of all, you don't need to, but secondly, you'd increase that vascular risk. But I just want to show what we've achieved with just that small amount. Actually, let me take this marking off. So what we're going to have a look at now is the projection where the light bounces off, and also the angulation of that cheekbone, which I think is exactly what we were hoping to achieve.
And Tristan, when we're putting our pilot needles in, there's a few tips from the gem on how to increase patient comfort and the best way to do it.
Very true. Should we talk through that?
Let's do that.
So why don't you talk through that, Jay?
So we're going with bevel up, which is the cut-out part of the needle. We're going bevel up. We're only going as deep as we need to go, so just into the dermis. We're applying the fewest number of insertion points as possible.
And one final thing is that we increase the tension on the skin. So the tighter the skin, the more pressure when we put our entry point through. So as Joe said, bevel facing upwards increases pressure. Tightening the skin increases the pressure. And what that does together is it makes it more comfortable, because actually the higher pressure injection at the sharpest point will create the less amount of pain for your patient.
That's our pain gate theory, isn't it? C fibers versus A delta fibers, pain versus pressure.
Okay, so similarly, if we tighten the skin like this, we increase the pressure, and it allows us to traverse through layer 3, where we can create this light reflex, this point of light reflex. And then we can tail it back along the zygoma in the subcutaneous depth.
We want the appreciation of depth within a space here as well, don't we? We don't want to be right on the very most superficial aspect of our subcutaneous tissue. We're going mid to lowest points of that. It's very hard to then go back through the muscle at this point, isn't it? So
Exactly, yeah. So there we are. I think really important also here to mention that we've created a deliberate shape under the skin. It's tempting to just flatten it. Whenever we work in hospitals and we make a little entry point, we always want to immediately press on it with our gauze. But in aesthetics, we have to be mindful of the shape that we've created, and we can sometimes reduce the edges if we want to create some blending, but generally we can avoid harshly flattening the new injectable shape that we've made. So now I'm just doing some final balancing to make sure we've got the same on each side in terms of definition. Now let's have a look. So sit forwards into the camera for us.
nice.
Turn this way slightly, and this way. You can really start to see. Now it won't look quite as sharp as that in the final result as it settles. But on day one, you can definitely see the additional definition that we've created. This will definitely soften over the next 2 weeks. But it's an additional feature alongside the projected apex of the cheek, which I think is really nice. Okay, head back. Now, second treatment in the sequence is going to be the Pyriform Fossa.
What we learnt in aesthetic medicine even 1 or 2 years ago is now outdated. Why? Because aesthetics is still a relatively new science, and the research underpinning our work, particularly our understanding of anatomy, has advanced significantly. Hello, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I want to introduce you to GEM, the Global Evidence Matrix. GEM is a dynamic, evidence-based framework that gives injectors a clear, consistent guide for safe, effective treatments, all grounded in science, not in corporate sales pitches. GEM combines clinical research, anatomical knowledge, and injector expertise, and it's always updated with the latest evidence. Think of GEM as your interactive map for facial aesthetics, guiding you through every step from technique to product choice. With GEM, you're not just injecting, you're working at the forefront of medical aesthetics. Join us in setting a new standard for safety and results.
So with aging, what happens to the maxillary bone is that it retrudes, it moves backwards. Okay, say that again. With aging, the maxillary bone moves backwards, but the angle also decreases. So if this is the bone moving backwards, it also drops like this. And what that means is you get this gap, this depth, that means that the deep cushions that sit on that bone start to hang downwards. So by supporting this with some volume, we reduce that angle of the flattening and reduce the shadows that appear at the base of the nose. So we're going to do a little injection either side, using a 25 gauge needle here to improve the sensitivity of the aspiration. So nice and still for me, Amy. 1, 2, 3. Well done. Touch down onto bone. And for these types of areas, piriform, chin, temples, I'm always wanting to do a good 10 seconds aspiration. Jay, do you want to talk us through some principles for aspiration and safety?
Yeah, so it's a contentious issue in aesthetics. We are pro-aspiration in areas of high risk. So Pyriform Fossa, we are concerned about the course of the facial artery into the angular artery, which will then give off our dorsal nasal artery. So we've got some pretty big vessels in that distribution. We want to increase the sensitivity and specificity as much as possible. So we're using a slightly wider gauge needle. We're using a 25. It's a nice long aspirate, so we're allowing time for backflow. Tristan didn't cover up the hub of the needle, so we're able to see the second that we get any flow back into the chamber. The injection speed is low pressure, slow injection. And you can see that Tristan is observing the skin and soft tissue surrounding the area, looking for any changes or any particularly immediate blanching of the skin that would indicate that there might be a vascular adverse event. Really slower than you think that you should inject. That's how slow you want to inject. And then to make sure that we don't get a lot of tracking through the layers, we're also pulling the needle out really slowly. It's a wider gauge needle. We do worry about backflow. So a really slow exit as well as a slow injection.
I wonder if we should just take a look at the midway point for that injection. I always think it's quite a subtle injection, but hopefully you can appreciate on this side the reduction in the shadow at the base of the nose, which isn't, I wouldn't say it's a nasolabial fold, but I think just the positioning of the maxilla now compared to the other side, it's pointing forwards rather than backwards. And that gives you this subtle youthfulness to the midface.
And widening of the piriform aperture is one of the more early signs of aging and changes in the skull. So in your 30s, we're not going too early.
Okay, same on this side. The place that we want to inject is going to be the shortest distance from skin to bone. So there's no particular rule to it apart from where you want to feel it the most shallow in the piriform fossa. And again, 1, 2, 3. Well done. Amy did great there. Make sure we have bony contact, it's really important. And we keep bony contact all the way through this injection.
So again, nice slow aspirate. You can see the chamber of the needle. Maintaining contact with the periosteum. And a very slow injection. Looking at the skin surrounding soft tissue.
Great. Lovely. Back to the camera, please. Great. You can see yourself in the shot there if you want, Amy.
It's perfect. I can feel it starting to numb up a bit as well.
Yeah.
Oh, it's really weird feeling.
So the reason we get some numbness in the upper lip when we treat the Pyriform Fossa is because the infraorbital vessel and the nerve, they fan out towards the base of the nose in the Pyriform Fossa, and then they supply the upper lip. And this is a sensory nerve. So if we use lidocaine in our product in this area, we're going to get a little bit of an infiltration to the nerves supplying the skin of the upper lip.
I think that's quite a good way of assessing whether you're in the right depth as well.
Yes.
If the patient experiences some numbness, you know you're deep with your product.
There'll be a bit of tingle, that's it.
We like a little bit of tingle. Right, let's go for a tear trough treatment.
Okay.
So let's use this opportunity to just recap the anatomy of the under eye region. So let's find the bony origin of the orbicularis retaining ligament. So these white dashes here, if you just sit forwards a little, head up a little, and look into there, look into there. Yeah. So these white lines here indicate the superior margin of any injectable treatment in the midface, but particularly the tear trough. So this is the origin of the key ligament, the orbicularis retaining ligament. And we notice that there's a little bit of a slip off of the soft tissues with aging that reveals some of the bone here. So you can see that we have what's called a palpebromalar groove laterally, which is an important target. It's not the tear trough, but it's part of the infraorbital region. We then have the nasolabial fat pad, which ends here as the nasojugal groove. Your patients may have a groove here that they confuse as a tear trough, but it's not the tear trough. The tear trough is the gap that we have between this nasojugal groove and the tear trough ligament, which is the medial aspect of this orbicularis retaining ligament. And the final thing to just draw on here is the medial limbus of the iris, where we're going to get the zygomatic cutaneous ligament off like this. And so here it gives us a good anatomical overview of what we're trying to treat, which is the tear trough itself. And this is this very narrow band between the nasojugal groove and the tear trough ligament. We have the palpebromalar groove, which is where the souph and the subcutaneous tissue is slipped downwards and revealed a bony ledge. And so we can treat the fat that comes between the lamina of the orbicularis retaining ligaments. This is our palpebromalar groove treatment. We've already treated the cheek apex, you see, and this was a treatment of the souph itself. And so I'm happy that I've restored volume, and we should be restoring volume in the deep cheek compartments before moving on to the tear trough. But the treatment technique for this one is, number one, we're treating the tear trough, and number two, we're treating the palpebromalar groove. So let's progress through the skin, and then I'm pushing through orbicularis oculi muscle. And this is now my depth that I want to be in for the tear trough treatment itself. And then let's advance just into this exact area here between the ligament and the nasojugal groove. And I'm doing tiny deposits of Revenes Revise here.
You'll see it looks like the cannula is really superficial, but actually it's just because the layers of tissue here are also thin. So we have very thin skin, we have a very thin muscle here, the orbicularis oculi is thin, very, very little subcutaneous tissue and pretty much no deep fat here. So that's why it looks like the cannula is superficial.
Remember, we're only really treating to 80% correction. I'm going to treat the lateral aspects of the infraorbital region, and then we're going to take a look at this entire under eye. So I'll make a second entry point here. And again, I'm pushing through the skin, through the orbicularis oculi muscle. And then I'm doing more micro droplets along the palpebromalar groove.
This is an easier treatment to do with the patient's eyes open and looking up a little bit, isn't it?
Yeah. If you push too much against the ligament here, it's very painful for the patient, so you'll know your boundary, your patient will tell you. In total, I've used 0.3 mils so far. Rarely does this require any massage. I'm just taking a look. Okay, so now let's see the impact of the tear trough treatments. Sit forwards. Okay, great. So I hope you can again appreciate on this side the transition now from the cheek to the eyelid. And actually, despite the underlying anatomy and the intraorbital fat, I think that's a really nice transition. If you close your eye, I press here, you can still see where the bulge would look like. But actually, if you open your eye, turn this way, that for me has been significantly treated. And just to mention that it wouldn't be possible to get that kind of results if we hadn't restored the appropriate fat pad targets in the midface beforehand. And that's why we have our injection principles of starting lateral and working medial, deep to superficial, and top to bottom. Let's treat the other side. So let's talk about some of the things that can cause complexity when we're treating the under eyes. And one of them we can see today, which is the intraorbital fat pads, which can then create a bit of irregularity in an eye bag under the eye, which then is very difficult to create perfect transitions. Just look upwards. So that's one of them. Another thing our patients sometimes come with is pigmentation under the eye. And if they have pigmentation under the eye, then turn this way a little. Sometimes reducing the hollowing can help because more light bounces off. But generally, pigmentation isn't something that's directly treated with these hyaluronic acid fillers.
I think if it's a vascular pigmentation, that's when it's quite useful, isn't it? In lighter skin types with vascular pigmentation, allowing a little more depth between the vessels and the surface of the skin can give that kind of artificial improvement in it, can't it?
That's a really good point, yeah. But if it's more like to do with skin type, yeah. So there's pigmentation, there's intraorbital fat pad pseudo herniation, i.e. eye bags. Another one is lots of excessive under eye skin. That can increase the risk of swelling, edema, overfilling as well. The third one is malar edema. If your patient has a collection of fluid in this region where the soof is, then often if you don't want to put hyaluronic acid in the region where we know the lymphatic channels are, which is in the soof itself. But if we have hyaluronic acid in the region, for example, the tear trough, it can also create worsening of malar edema.
Mm-hmm. I think tear troughs are one of the areas where you have to choose your patients so carefully, isn't it?
Yeah, patient selection is how to avoid those issues.
And this lateral approach looks like a much more suitable approach to the lateral tear trough than trying to approach from the same pilot needle point as when you're approaching the medial tear trough, yeah?
Yeah, otherwise you're trying to navigate the tissues and it's very awkward.
Yeah.
And it can be painful and you can't get the same angles. So I always like to have 2 different angles for that.
And pass through extra ligaments. You've got your zygomatic cutaneous, so you have to
Yeah, absolutely.
manage.
I'm very happy this is the full mid-face treatment now done. We're going to move on to the nose.